Okay, we're talking about migraine headaches. Boy, do I hate taking a chart that says headache. That's a great resident case, right? It's always a good resident case, or even better, a medical student case. However, God sends tension headaches to the office. He sends pseudotumor, subarachnoid, and brain tumors to the ER. Pretty smart. So we see in the ER, I think, a much higher incidence of severe problems with headaches than does the average office doc. You go to a doc, you got a headache, you look okay, you get some Percocet or some Motrin, and sends you home. In our place, you get a CAT scan and all sorts of blood tests and probably an LP. So I think it's a very different way we work up patients. That's probably because there is some sort of shunting of the sicker patients to the emergency department. Now, we see a lot of patients with migraines, and usually they're in our hospital because the stuff they usually try doesn't work. They may not have their own doctor. Or they have something that makes this particular one worse than the other case. So I think we see a skewed population of the migraine headaches. I had migraines when I was a younger guy, and I'll tell you, it's pretty miserable. It is very incapacitating. The nausea is extreme. The pain is terrible. And, but however, if you were to diagnose a migraine on me for the first time at age 50, you'd be on pretty thin ice. So there are many diseases that don't start in old age. So you don't usually get a herniated disc, by the way, for the first time when you're 70 years old, right? That's kind of, think of the people you see with herniated discs. 30, 40 years of age, right? How about kidney stone? 80-year-olds don't get their first kidney stone usually, okay? Schizophrenia. If you're wacky and hearing voices at age 45 or 50, it's probably not first onset schizophrenia. Same with migraines. And I know migraines are childhood migraines. It's actually a fairly common cause of bad headaches in children. We see occasional kids in the hospital with nausea, vomiting, and severe headache, and we get all excited over that. The pediatricians tell me that there's a fair number of childhood migraines. Where's our pediatrician in the audience? Do we have one here? No? Couldn't get up this early? All right. Well, anyway, it is not uncommon to get migraines at age 8, 9, and 10. However, there's no ER doc in the world who's not going to do a CAT scan on someone who has nausea, headache, who's 8 years old, is crying with pain, right? You're going to do a CAT scan on those patients. But that can be a migraine when everything else comes out negative. Number 1, 2, and 3 are the complications of migraine headaches. This is a very sobering article, number 1. How many times do you see migraines that have come back for the second or third visit and they're still having a headache? You get pretty pissed off at that patient, right? You get frustrated, you know, what do you want me to do? You see a neurologist, et cetera. You also get patients who have these hemiparetic migraines, which really look like something bad going on in the brain. Number 1 says that some bad things can mimic migraines to begin with. So if someone is 23 years old and you're diagnosing the first migraine, again, you need to think about it a number of times. If they've had all the tests for migraines, CT, MRI, neurology consult, and they're pretty sure they have a migraine, I think you're on fairly safe ground assuming they do have a migraine. The 2 questions, of course, you always ask every patient: have you seen a doctor for this before? All right. And what do you think it is? All right. So if someone says, I got a migraine, doc, you know, if it's their diagnosis, I'd be a little careful. But then the next question is, well, tell me about it. Did you have a CAT scan? Oh, I had all the tests. I had a couple of CAT scans. I saw the neurologist downtown. I went to the headache clinic. I know this is my migraine. It's just like the ones I've had. It's just not the medicines aren't working, or it's a lot worse this time. I think you feel a little bit better about being able to just treat them and give them a little lower priority. However, if they say, yeah, I got a migraine, and say, well, how many do you have? Well, this is my first one. Who told you I had a migraine? My mom said I had a migraine because they threw up with it, okay? And she has migraines. So those are the ones that you have to be more careful. Number 1 says that migraines can lead to stroke. Now, we've seen a number of cases where the patient actually probably had a migraine the first time, and then as the migraine persists and continues, the vessels involved become necrotic because of the intense vasoconstriction to the blood vessels going to the blood vessels. Remember, blood vessels have to get blood the same way as nerves need blood and so on. They get a little necrotic area, and that what started out as a classic migraine, which you saw 4 or 5 days ago, which actually was a migraine, and had you done every test in the world, you would have been okay. 5 days later now is a subarachnoid hemorrhage or an intracerebral hemorrhage, okay? Not because you missed it the first time, what you'll be accused of, okay? But the fact that this migraine then went on to hemorrhage. Intense migraines can also lead to ischemic strokes. So they may not have had a stroke when you saw them. They actually had a true migraine. 4 or 5 days later, they come back with a stroke. Well, what's everybody going to say? Well, you obviously missed it the first time because you didn't do a CAT scan of that particular patient. So this is a very tricky issue. I've seen a couple of these. I know they always make their way to patients not being happy with their care because they can't understand the fact that that they have a migraine. So there are a couple of tip-offs, all right? If you see a migraine that's been there for 5 or 6 days, that's not your typical first time, give them a shot of Imitrex and send them home, okay? As soon as the husband says, Doc, don't you think you ought to do a CAT scan? Your answer is, I've already ordered the CAT scan. Didn't you get that yet? Okay. So yeah, do that. You never argue about a CAT scan because they know what the migraine's like. There's something that made them come there, something a little bit different. The other one is, do you think she should see a neurologist? And my answer is, would you page that neurologist again, please, clerk? So sure. If you have someone asked to see a neurologist for their migraine headaches, you're damn sure either do what you can to make that happen. Okay, because there's something about that headache that's a little bit different. Again, the public thinks that surgeons know all about appendicitis, that the cardiologists know about heart attacks, and for sure, strokes and migraines, that's a neurologist's disease. So you want to share the liability as well as get some information to help your patients out on those. So just read number 1 and 2 and 3, and you will be surprised how many migraines actually turn to something really bad. And of course, there's no way to predict it. No way to predict it. The aura is not particularly predictive. My sort of gestalt is that if it's worse, different, or specifically prolonged, those are the ones that may have more of a chance of being a problem. So if you've had 4 CAT scans of your head for migraines, and you've had a migraine for a week and a half, and you see 3 doctors, I'm going to repeat the CT and probably the LP, and probably an MRA and an MRI and an MRV. Just like the neurologist did, right? You can't get a neurologist to see anybody without an MRA, MRI, or MRV. Why should we have to do it, take those things? That's the Dirty Harry approach to medicine, right? A couple of big quotes on Dirty Harry from San Francisco. First one is, man's got to know his limitations, okay? As a doctor, you're not as smart as you think you are. The second one is, remember when he shot the gun at the guy, and then he goes to reach for his shotgun, he holds the gun, he says, I don't know how many bullets are left in here, but I got one question for you. Are you feeling lucky, punk? Okay, so if you're feeling lucky, punk, you can send that lady home without a CAT scan, with her migraine. Okay, so share the liability. A couple other things you learned this year: never use a quinolone unless you have to. Right? It's not your money. Right? Share the liability. And there's an opening at the shoe department in Nordstrom's if you really want an easy job. So those are the things that you want to sort of factor in. You can, how about these hemiparetic migraines? You've seen those, right? They don't always have to have a very bad headache. The headache can be relatively mild or they have a history of migraines. We see these fairly frequently. They're scary because they're usually young, healthy people who come in with some slurred speech, some vision trouble, maybe some dysarthria, and they have a hemiparesis. I mean, that's a thrombotic stroke with a normal CAT scan, right? So the question is, do these people, this drives me nuts. You don't want to miss a CVA in someone like that, and this could be a perfect candidate because it's a young person. One of my partners saw a guy, 24-year-old like this. He says, I don't know what he has. He sounds like he got a stroke, but he's 24. He's not hypertensive, not diabetic. But it looks like he's got a stroke. The CAT scan was normal, and he's hemming and hawing. He says, I'm just not going to give this kid TPA because I don't think he has it. Turns out the guy had a patent foraminal valley, and he had a thrombotic stroke. Okay, and now the guy is severely disabled. Who knows? Patent foraminal valley. You need to know about that. So if a 24-year-old can get a stroke from the first attack of lupus, okay, and they don't have to have these protein S, protein C deficiencies. So this is a foraminal valley. It's pretty hard to convince someone that you didn't something you could have done when this poor 24-year-old now is in a wheelchair and can't feed himself. A devastating disease, stroke, very devastating. So the migraines, and I've given TPA to a couple of migraine patients, and fortunately, they did well, but you got that 12% chance of people having trouble. So, any questions about sort of the presentation or complications of migraine, or any cool migraine stories? There are common drug-seeking behavior because you can't prove the patient doesn't have them. Yeah, those are always tough ones. But I don't fight over 6 Percocet for anybody. You want some Percocet? Here you go.
No, the question I have is that how do you...
To get what? Oh, it's very hard to get the MRI. Those jackass neurologists won't do it for you. So I say they have a hemiparesis. I lie. They have back pain. We don't do stat MRIs on people without any neurological findings. Well, the guy has trouble moving his right leg and he just became incontinent. Then he calls you up and he says, "You told me this guy." I'm really sorry. That was the other guy, I'm really busy here, It's like the insurance, You ever get what kind of insurances he has? Let's see, what one is the best? He says, well, Blue Cross. Yeah, that's the one. He's got Blue Cross. They come down all pissed off. Geez, I'm so sorry. It was that other guy. I got him confused.
The other question
it's very hard to get them. You got to push for them, and you got to lie.
Because it's the same thing I have to do. It's not
You still need to do an MRI or an MRA when you're looking at subarachnoid hemorrhage.
If you do the MRI, do you need that?
The answer is yes. You still have a couple of percentages that you're going to miss if you want to get every one of them. You can usually figure those out, people that have sudden onset of headache and a little nausea and vomiting and the negative CAT scan, you're supposed to do a CT scan on them. Well, a couple of things. You ask about the family history, which the disaster. No one ever. Yeah, 5 people in my family had aneurysms, doc, but you never ask me. Okay, and then you do your neurological exam and so on. But we're stuck on that. We do probably 30 or 40 LPs that we don't need to do only because we don't want to miss anything. I mean, who here has seen someone with a completely pristine neurological exam, which you'll get with a subarachnoid, right? You don't get any hemiparesis with a subarachnoid. You might get a little bit of stiff neck in them, which is fairly common. But who has done an LP and been surprised when they didn't think the person had a subarachnoid? Yeah, a couple. All right. Any advice for us on what to do? I mean, it's just sort of luck of the draw, I think. I think when you look back in these cases, there's something a little bit different about it. I saw one in court a while back where this 18-year-old's walking down the street, said to her friend, "Oh my God, my head's killing me," and she faints. Okay? Now, sudden onset of severe headache, worst she's ever had with syncope. I mean, that ain't tension headache. Okay? So the doc does an LP, gets back blood. He says, traumatic tap. Sends her home because she got better with a little compazine, call it a migraine. Died. So, about 20% of subarachnoid hemorrhage, they never find a cause for it. Yeah. You get a subarachnoid, you've diagnosed it by one way or other, you do angiogram, never find anything for it. Never find it. And if you diagnose it in somebody, tell every family member you can that's in the room, you got to get yourself an MRA to make sure you don't have one. Yeah.
Our neurologists feel that if you do a CTA, why do the LP? Because if the LP is positive and the CTA is negative, they're not doing anything about it anyway.
Right. If you don't find anything in the MRA, why bother the LP? Because there's nothing going to do to intervene on it. Well, I'll tell you why, and he can call me if he wants. Vasculitis, okay, that's one good reason, which they can usually see on an MRA, I guess. But I agree. Yeah, you want to be again. Listen, this is hard to do this stuff.
I had a discussion with a radiologist at the department, and they told me that a few weeks ago that you don't need to do the tap, but they had a case where it was a 2-millimeter aneurysm that was not seen on
Right. Well, they didn't see, you don't have to be a rocket scientist to be a radiologist, right? They miss things. They miss aneurysms. I think in the NINDS study, they had neuroradiologists reading the study. And didn't they have something like a 10 or 15% discordant reading between the neuroradiologists in this NIH study looking for blood? Yeah. I mean, the CAT scan's pretty good for blood, but it's not 100%. Number 6 is the Bucata School of Title Writing. Favorable response to analgesic does not predict a benign etiology of headaches or chest pain or about just about anything else. Okay, so this is. I think we're pretty smart enough now that we don't realize if you give somebody a shot of compazine and their headache goes away that it's a diagnostic test. Same way you don't give them a slug of Maalox, and if their indigestion goes away, it's indigestion. It's not an inferior wall MI. So we're pretty much over that. Any smart doc is going to realize that even nitroglycerin or drugs that are specifically directed toward a disease physiologically that makes sense, like giving a triptan, just because it goes away doesn't prove a whole lot. I think it helps a little bit, okay, and you can factor it into it. But you've seen these pristine people that come in with symptoms you've never seen before, and you give them an intervention. Just being in the room, if you can wear your white coat in the room and raise their blood pressure to 200/110 factitiously, you can be in the room and get rid of that chest pain from a LAD occlusion, right? So you have to be careful about anything you do. It's pretty much common sense. This is a meta-analysis of 18 articles looking at triptans and other analgesics, and found that they did not predict the present. It's not a diagnostic prediction, okay? Venous thrombosis, brain tumor, pseudotumor. God, must have 50 patients in our catchment area that have pseudotumor cerebri. Very, very common problem. You'll miss a negative on the CAT scan, right? Always a normal CAT scan. You got to do an LP with the opening pressure. Half our doctors do an LP for headache and don't do the opening pressure, all right? Which is crazy because that's the only way you're going to diagnose pseudotumor, and that's a bad disease. It causes migraine-type headaches, causes blurred vision, it causes blindness. And you got a couple people walking around Philadelphia blind from their pseudotumor, having seen a whole passel of doctors who said it's tension because your CAT scan's negative. All right. By the way, the same radiologist who won't do the MRI for you is the one who writes on the CT scan cannot rule out subarachnoid hemorrhage, meningitis, or pseudotumor. That's on every CAT scan that we read now. Yet, don't ask me to get one of those tests, but you just can't do it.
I actually confronted one of our radiologists that way, and I said he had written, you can't rule out CEA, you need an MRI confirmation. I said, you can't authorize to look at the MRI, right?
Yeah.
I said, either take it off there or do the MRI.
You can't talk to these guys about that. And you can't talk to them about calling you and telling you that your partner who ordered the test 2 days ago missed something, and then they hang up the phone and figure you're supposed to do it, and they put your name on the report, right? Their society says that they have to tell a doctor about the test because this is a huge issue. That's why I told you need a nurse to do this. If you're a doctor taking this stuff from the radiology department and try it in the busy shift, trying to follow up on nodules and adenopathy, that's going to fall through the cracks. But they put that on there, and we can't win that battle at all. I don't know. Same way with our CT spine, our cervical spine X-rays, MVA neck pain. Everything's normal, pristine. However, you need a CT scan to rule out trauma for the cervical spine. Will you do the CT scan? What kind of insurance does he have? Or send him back tomorrow. We'll do it tomorrow, or something like that. Again, this is life in the big city. We've all learned how to deal with that one. Let's just say you actually are correct in your diagnosis of migraines. Any drug we have, there's a whole bunch of them in here, about a 60 to 80% positive response to an intervention. None of them are 100%. There's about a 20 or 30% placebo rate. A lot of these studies are drug company sponsored. There's from 8 to 16 is all about sumatriptan. Sumatriptan is a serotonin agonist, right? What a serotonin does is it constricts the blood vessels. Supposedly that's the etiology of the pain, this vasodilation in the migraine. The aura you get, seeing funny spots and stuff, that's vasoconstriction, and the hemiparesis is vasoconstriction, and then the vasodilation is the throbbing headache. So there are really two ways to manipulate chemically against the migraine. One is serotonin. You want to give them serotonin. Serotonin's good, so you want to give them serotonin like the sumatriptan, and you want to do a dopamine blockade, which is your compazine, thorazine, droperid, all those sorts of things. So you want to mess around with this, with the serotonin and the dopamine in the brain. So all these talk about a fairly decent response to the triptans, Imitrex, Maxalt, Axert, Zomig. I honestly have only used sumatriptan Imitrex intramuscularly a couple of times. Seems to work in some patients. This is another one of these things where you say, what usually works? Unfortunately, the answer is always, 8 milligrams of Dilaudid is the only thing that really works for me. But, the real patients who are there, if they had something that worked for them, they wouldn't be there, right? So we are at a bit of a disadvantage when they talk about all these studies. I think most migraineurs don't go to the emergency room. The ones that are difficult to control, become addicted to drugs and so on, those are the ones that we have to deal with. So our job, I think, is a little more difficult than some other people. Plus, we don't have the benefit of every laboratory test and scan known to man, which the neurologists have. So we have to choose on what to use. So this is kind of a class discussion here about what you think is best. My approach is compazine, number one, with Toradol. Now, I haven't seen that actual one studied, but that seems to make some sense to me, and I think it works a fair amount of time. Compazine is a dopamine blocker. It also does something to serotonin, and there's articles in here that says it works about 60-70% of the time. It's cheap. The only side effects of it are really they can get dystonia. Some docs give Benadryl along with it. I don't know if this dystonia. My residents don't want to give Benadryl with the compazine, because when you give the compazine, the reaction is this akathisia. I say, I got to go, doc. I got to get out of here. I just have to leave, which is, that's the filet mignon to a resident. Hey, he wants to sign out, just sign him right here. So. But anyway, so you can read all these, and they all, compazine, Reglan. Reglan, at least in the study, seem to have a little bit more anti-nausea effect than pain effect. I'm not a big fan of Reglan for migraine headaches. Some people give it. I must admit, if I have someone who's nauseated, I'll put 20 or 30 milligrams of Reglan in the liter of saline and run that in sort of as an adjunct after I give my first dose of something or other. A lot of gastroenteritis that are a lot of nausea and vomiting. I don't just give the 10 milligrams of Reglan. I put it in a 10 or 20 into the bottle and run it in over a couple of hours. That sounds kind of fancy. Whether or not that is any better, I really don't know. Everybody's using Zofran now anyway for nausea and vomiting. I haven't seen Zofran used for migraine. So give me some ideas of what you think is best for migraine headaches. What's your choice? Anybody have a particular choice? What do you do in the office? Somebody comes in the office and says, I got a migraine today, it just won't go away. What is it? I am Toradol. Yeah, does that work, you think? That doesn't really have any pharmacological manipulation other than the fact that it's an analgesic, so at least that I'm aware of. Yeah. Toradol's not a bad drug, I guess, for something like that. Dr. Bucata doesn't like Toradol. Yes?
One of my neurologists just giving magnesium.
There are about 10 articles here on magnesium. They go from the greatest thing since sliced bread to why waste your time. Remember, there's a big placebo effect in here. Propofol. There's an article here about giving 20 or 30 milligrams of propofol till the pain goes away. Droperidol. I like droperidol. That's great anti-nausea. 2.5 of droperidol IV. Haldol even. The classic one was Thorazine, right? When I was growing up, everybody got Thorazine for headache. The only problem was it made a lot of them hypotensive and so on, but we don't use that very much. Cocaine. Cocaine will get rid of a headache. Sigmund Freud used to use cocaine all the time for his migraine headaches. Lidocaine up the nose has been used. Sphenopalatine ganglia. I've used Maxalt a couple of times. I always ask the patient, the best way for you to learn what works for migraine, every time you see a migraine patient, ask them, what has worked best for you? Well, the amitriptyline never works, or that sort of stuff. And you'll get an idea of what to give them. They say, yeah, this works for me, or this doesn't. They all think, of course, when they get dystonia, they're allergic to the compazine, so you can't give it to them anymore. Same way with lupus. You see somebody with lupus, ask them, how'd your lupus get diagnosed? That way you'll find out what the presenting signs of lupus are to the ER. How about MS? I've seen a number of cases that the diagnosis of MS was, I'm numb from the neck down. In a young woman. Now, she's got to be nuts, right? How can you be numb from the neck down? Can you feel this? Yes. Can you move it? Yes. Yet you're numb from the neck down? Yes. Here's some Xanax, go see your doctor, right? No, that's MS. Question? Yes, Botox for chronic recurrent migraines, yes.
As a preventative,
Right.
like a 15-shot, or 10-shot array that would actually work pretty well. And then, as a lot of friends, it just gives the people too flexible. When they're asleep, they stop complaining of their migraines.
Yeah. Yeah, well,
It has a serotonin effect to the brain.
I can tell you the holy grail for a migraine is go to sleep. Because no matter what that does, something happens to sleep. If you can get to sleep with a migraine, that's why I use a fairly high dosage of drugs. If I'm going to use morphine, I'll give them 15 milligrams of morphine. I'm not going to mess around with 2 or 4 milligrams. You want to put them to sleep. This Botox is actually it's coming under a lot of scrutiny now by the FDA. The FDA finally got religion now, and they're actually looking at the drugs that they say are okay. But look at the steroids. How about steroids? Everybody use steroids? Numbers 49 to 56. You ought to look at these. I do this a fair amount. Someone's had a migraine for 3 or 4 days, or everything else they've tried it. Give them 10, someone up to 24 milligrams of IV Decadron. Give it slowly. 24 milligrams of IV Decadron will make a lot of people vomit. So just be a little bit careful, or make them really dizzy. But here's what you treat their migraine. They've had it for 3 or 4 days, and they say, "Well, doc, it oftentimes comes back." Give them a shot of Decadron. Just give them 10 IV. Not great, sort of like it is for sore throat. Maybe helps some people. We don't know who it does. But I've had some fairly decent success with this, not as an acute treatment, but to prevent recurrences. Because when they go home and the drugs wear off, they're going to have their migraine again. So keep that in the back of your mind. If there's no contraindication, give a couple of them some Decadron, see how it works, see if they come back again. And I also like the injections. Now, not the Botox injections, but your last one on here talks about lidocaine injections. You find the pressure point of where it hurts. Usually it's either temporal or occipital, and you have to do this about 3 or 4 times so you really know where they hurt. And then you go in there and just inject it with bupivacaine or lidocaine. This is old trigger point therapy. I found it works fairly well in some patients. The pain clinics who do trigger point injection, even with saline, have some pretty remarkable results if you know how to do it. Sort of like acupuncture, I think. You stimulate the right area. The final one that you may see, and I see it a fair amount, is the people come in and say, "I have this lancing headache. Every couple of minutes I get this shooting lightning pain right here, and it goes over here." Have you seen those patients? And they cringe and it really hurts like crazy, and then they're pain-free. And you're wondering, man, you got brain tumor, what's going on? That's probably occipital neuritis. And I've had some fairly good success by right in the occiput as the nerve comes out of here. You just fill it full of lidocaine, and sometimes you put a little solumedrol in there. A lot of that may be a little bit of voodoo, but injecting. So if you have someone who has a trigger point on their head, next time everything else has failed, just give it a try. Go around and say, does this hurt? Does this hurt? And he says, that's tender right there. So you put a little X on that area, and you find a couple of places, and sometimes you'll get 2 or 3 places you could inject, because a lot of these so-called migraine headaches are actually tension headaches. And if you look at the physiology of migraine versus tension, they're very similar. We do these PET scans on people that have so-called tension headaches. There's a lot of weird stuff going on with just tension headaches. So these muscle contraction tension headaches can give you very migrainous type symptoms. So don't forget about injecting those areas. Patients, that's a real hands-on thing, right? There may be a big placebo to it, but the patients love it when you give them a shot. All right, some of them do. I like to give it to little kids, of course. But all right, any questions about migraines here? One, yes.
How are you selecting out these local injections? It sounds like it might be great in a small group of patients. How do you select them?
Those are the ones that have tender points that you can touch, that everything else fails. And there's some pretty good testimonials in here about it. The Australians, you guys using nitrous? There's an article in here about nitrous for migraines. Are you using it for that? Yeah. One case report got into the British Medical Journal. How hard can it be to get a publication in the British Medical Journal to get one case report in there? Great. Okay.